Hi, I'm Lisa Mistler. I'm an associate professor of psychiatry at the Geisel School of Medicine at Dartmouth. For the past 20 years, I have been an attending psychiatrist and director of the short-term unit at New Hampshire Hospital. Left in May of 2022, and now I'm a T32 postdoctoral researcher studying healthcare communication. Was that enough time? Okay. So I think we start out, we're going to have a few poll questions. I'm going to start with the first poll. Do you consider the occurrence of violent events as a normal component of direct patient care? I can give you a few minutes, a few seconds. Okay. Can I have the next slide, please, Carla? Oh, there you go.
Yes, I was waiting for the results. Okay.
Got it. I wasn't sure if it was going to show up or not.
Yeah.
Okay. So about 17% say yes.
Okay, I'm trying to advance. There we go.
There we go. Okay, thank you. So before I start too, I wanted to mention Rosemary Taylor and Raylene Shippey Rice, who are two folks who worked with me in creating the content for this particular presentation. I didn't want to leave them out. So thanks so much for the opportunity to present some of the work that we've been doing in New Hampshire to begin to address the idea of workplace violence in healthcare. And my job in this presentation is to give you sort of the overall context of the problem in 10 minutes. Good luck to me. Here's an outline of what I'll talk about. First, I'm going to talk about the prevalence. I'll give you some numbers from the Bureau of Labor Statistics. I'll talk a little bit about some of the costs associated with healthcare workplace violence, talk about the groups that are at particular risk, review some likely causes, and then I want to really focus on the need for data as the entree to the rest of the presentation. So here we go. Next slide, please. Okay, so talk about the prevalence. And most of the statistics that I have are from the Bureau of Labor Statistics. And according to a 2018 report, 73% of workplace injuries in the healthcare setting are due to violence. That's 3/4. And that was before COVID. They've had some surveys since then. A survey of nurses in 2020 documented an increase in violence against hospital employees linked to the pandemic. 44% of nurses reported physical violence and 68% reported verbal aggression during the early days of COVID. In an April 2022 survey of 2,500 nurses from National Nurses United, the country's largest nursing union, 48% of nurses working in hospitals reported an increase in workplace violence, up from 31% in the prior year. And as the pandemic worsened, so did the staffing crisis, as you might remember, and that worsened the existing violence associated. The rate of violence in hospitals alone went up by 25% from 2019 to 2020, according to the American Federation of Teachers report. And I just want to point out that this is one of my favorite graphs of this. This is violent injuries resulting in days away from work by industry. And can anybody find the green line? Because that's the one that's the highest, and it outstrips all of the others: private industry, retail, trade, construction, and manufacturing. So the intentional injuries caused by humans, excluding self-inflicted, are way, way higher, worse in healthcare and social assistance. Let's go to the next slide. And as I mentioned, this is the incidence rate of the non-fatal workplace violence to healthcare workers. Same Bureau of Labor Statistics. And you can see, I mean, the numbers march pretty steadily up, with the exception of 2015. The annual incidence rate is clearly growing every year. So next slide. Next slide. Oh, thank you. That's perfect. So This data source also comes from BLS data, and it covers ambulatory healthcare services, hospitals, and nursing and residential care facilities. And it says what percentage of the violence is perpetrated by who. And as you can see here, 80% of the violence in those particular situations the injuries were accounted for by patients. So that's what most of the research and literature is focused on. But we want to make it really clear that there are substantial numbers of healthcare workers. We want to make it clear that there are substantial numbers of healthcare workers who experience what is called horizontal violence, which is violence from their coworkers. There's a number of other violence that people experience, and you will see that in our New Hampshire survey results when we talk about that. Next slide, please. Yeah, I wanted to do that after the costs. Do you mind going to the costs? Is that okay? Next. Yeah, thank you. There are numerous costs to healthcare worker violence, and it's not just days lost or covering staff or workers' compensation costs. People leave because of this. They get burned out. There's a huge staff turnover. People feel very isolated. Their morale decreases considerably. We know that aggression on units is associated with increased use of coercive practices and decreased engagement. So patient care quality suffers from this. The costs are all over, not to mention the monetary costs, but I think all of these are just so compelling to me that workplace violence has had such an impact on people. Next one.
This one, Lisa, or keep going? Oh, I didn't know if you wanted to go back to this, but that's okay. Here's the next one.
Yeah, I do ultimately want to go back to that one. So this tells you a little bit more about who's most at risk. We know that emergency departments, mental health and substance use facilities, geriatrics, nursing homes, and ambulance services are the ones that most at risk. And you can see as the intensity of the care goes up, so does the likelihood of violence being perpetrated. And there's a good paper by Iacino in 2015 that talks about 20% of psychiatric inpatients end up committing a violent act. So that's like 1 in 5. Can you, yeah, I don't want I'll let you know when I want the tip of the iceberg. Thank you.
Okay.
Violent injuries resulting in days away from work by cause. And here in 2013, the most common causes of violent injuries resulting in days away from work across several healthcare occupations, as you can see, were hitting, kicking, beating, and or shoving. So there were a lot of very, very scary things that were happening. And so what are some of the causes, some of the underlying causes? That would be in the next one. And here I basically showed that all of this healthcare workplace violence occurs in the context of a violent society. Our country has pretty loose gun laws and things like that, whatever your personal view. But we know that there's a lot of violence in the US. So in that context, the patient factors that come up are, either the family, and there's some folks whose families actually commit the aggression, or the patient is unhappy with either their treatment, the care that they're getting, or the outcomes of the care that they get. And those are the things, patients also could be intoxicated. Patients could be, have a serious mental illness that is affecting their ability to maintain control. So those are some of the patient factors. The physical plant factors are overcrowded and poorly designed waiting rooms and work areas. And a lot of places have easy access and low levels of security, although I noticed that some people are now closing down their easy access and increasing security. Healthcare worker features are interesting because there are some folks who are identified as, sometimes making comments as an aside, but patients can hear them and they get angry, or that they're unprofessional. But it really comes down to abilities, skills in communication. And I think that's really key. And then finally, time. And yes, I'm anticipating Ellie's statement here, because not only is there wait times like in the emergency room, but there's understaffing. I put that into time. Oh, time isn't there. I'm so sorry. Maybe it's too late. Yes, so imagine a big, let's do yellow for time, understaffing and downsizing, and then availability of mental health services too. That's, one of the issues. So now we can go back to the tip of the iceberg. Thank you. So I gave you a lot of numbers here from the Bureau of Labor Statistics, but you may be surprised to hear, and maybe not, that these numbers are lower than what is actually happening in real worlds, particularly where verbal abuse is involved. But 50% of physical assault and 80% of verbal abuse, those two are estimated to go unreported, according to a study by Campbell et al. In 2015. So half of physical assaults and 80% of verbal assaults. Why do people not report their experiences as victims of healthcare violence? Well, there's a lot of reasons for underreporting, and I think somebody's going to be talking about that later on. But there's some issues, like there's a culture, it was at our hospital, New Hampshire Hospital, of that getting hit is part of the job. There's fear of retribution. There's, not wanting to seem incompetent, things like that. But I think they'll go into more detail. The part I'm going to focus on here is we also know that the numbers are only approximations, because the research on violence is hampered by several factors. So first, on the left, there are no consistent definitions of aggression and violence. So we aren't always talking about the same thing. Second, in the middle, although there are many measures that I've found when I've gone through the literature, and a couple appear in more than one publication, it generally is one measure, one publication, and we still lack well-researched, psychometrically sound measures that apply to particular situations that we know can be used to compare results between studies and between studies done by different organizations. And finally, most of the studies that have been done to date have not included the most essential stakeholders, which would be patients, in designing and executing the research. So we need to go to what started us on this journey, and I really, really apologize. Sorry about that. Okay. All right. So remember when I said research is limited? Here's the example. So what I want you to do is focus on all the little red X's there. This was an Agency for Healthcare Research Quality systematic review that was done, it used to be recent, it's now 2017, but by Gaines et al., assessing the strength of evidence in studies that examine what works best in reducing the incidence, reducing and preventing aggression. And you can see on the left, the stuff that prevents aggression, de-escalates it, reduces seclusion and restraint. And what is notable about this this particular table is that it is full of insufficient strength of evidence. So we really don't have a lot of information about what is most helpful to prevent aggression or de-escalate or reduce seclusion and restraint. At best, we have low levels of evidence for risk assessment. So the next, that brings me to the research practice gap, which is the next slide, I hope. Okay. So we don't yet have accurate and reliable data to measure the results of any interventions we develop, and the data won't help us target interventions. At this point, we don't have sufficient data in order to know if we've developed an intervention that it worked, that it made a difference, because we don't have a lot of baselines data. And then there are very few known evidence-based practices for us to attempt to implement at this time, but aggression and violence remain a problem, and we need to figure out how to deal with it ultimately. This is the opposite of the classic research practice gap that's been described in the literature, where The evidence base for effective procedures is established up to 17 years before it gets implemented. In this instance, what I want you to think about is each of our institutions, hospitals, ambulatory care centers, even in your ambulance or, outpatient facility, we're each doing our own interventions, right? We by necessity, and noting some positive things and some negative things. So some things work, some things don't. But as we've seen, comparative studies are few and far between. So we have little guidance as to what constitutes a solid evidence base. So here's where we could use your expert consultation. The efforts that we made in forming a coalition with an eye towards sharing data is not new. It's new in this field, but there's the Northern New England Cardiovascular Consortium, which decreased morbidity and mortality rates for cardiovascular interventions. And there's a National Cystic Fibrosis database. So there's a number of other kinds of consortiums out there, but not this one. And I'm going to ask you, could you envision a collaborative coalition that gathers workplace violence data, and the members of the coalition share their procedures to eventually create a solid evidence base for what works to prevent and manage workplace violence. So that's where we are. I believe there's a poll question after this.
For some reason, I have to click this like 17 times to get it to go to the next slide, so I apologize. Here's the poll.
Yeah, I'm sorry that mine were out of, I should have put them in the right order. Okay, from the following, what do you think is the most influential factor driving violence in healthcare settings? You have to choose one? Holy cow. So we wait until the answer comes up?
I think so. Kendra, will that come up soon? Yep,
all right. Well, this is interesting. So it looks like a lot of people believe that patients are less tolerant, which may be consequences of some of the things we talked about, increased waiting times, things like that. Staffing limitations certainly there, and lack of administrative action. COVID, for once, isn't like the top. So thank you for doing that. And now I'll turn this over to Peter.
Hi, everyone. My name is Peter Antal. I'm one of the lead researchers on this effort. So I want to talk a little bit about kind of what we did as a result of a lot of the baseline work that Lisa and others on the team have been engaged in. Part of that was some previous research that they had done looking at different hospital care or different healthcare settings and asking about this issue of violent events occurring within the healthcare framework. And out of that, we saw really the highest proportion of violent events were being reported within those ED settings. And so what we did with that then was to take, we invited 6 hospitals to participate in kind of a learning opportunity to conduct an updated survey of looking at, who are the demographics of the people that were providing care in the ED, to what extent was violent events happening, what was done about it, was there any follow-up, et cetera. And just as a side note, you'll see my email address in this presentation and some of the downloads. We do have the survey tool available for anyone that's interested in getting a copy of it. Just simply email me. I'd be happy to send the survey tool out. The report is also available here within the presentation as a download. We got about 26% of those responding. So this was an anonymous survey link that was sent out by each hospital to their staff. So anyone that was engaged in services to the ED. So it could be a healthcare provider, could be a support staff person, could be an administrative staff person. Anyone connected to the ED was invited to participate in the survey. Next slide, please. Definitions that we used for identifying whether or not an event was violent. We used OSHA definitions for these different areas. So physical aggression, kicking, hitting, biting, sexual aggression, actively touching or grabbing someone in an uncomfortable way, verbal aggression, words, phrases, conversations, anything that's threatening, name calling, This also included inappropriate verbal sexual advances, was fell under the definition of verbal aggression, and then harassment and intimidation. So we asked each person responding to identify whether or not these events had happened during the past 6 months at the time they took the survey, which occurred during the summer of 2022. Next slide, please. So almost everyone said they had experienced verbal aggression in the past 6 months at one point or another. 2/3 physical aggression, again, almost 2/3 intimidation, close to half harassment, and 1 in 5 sexual aggression. So as you can see, out of those people that responded having, and sorry, let me say, so this was 162 out of those responding. So out of those that said they had a violent event, 96% of them said it was verbal aggression. So the numbers are a little bit different when talking about total extent. So I think it was about 75% or so if you're looking across the board and all people that have responded to the survey. Next slide, please. A really important piece of part of this research is getting to have a better handle on what's happening as a result of these events when they happen. Because for a lot of people that are on the front lines, they've come to just expect this kind of thing, this violent events, as part of the norm and part of an expectation. And so we said, okay, well, maybe they've just gotten used to it and maybe not such a big deal. And so we felt it was really important to start documenting, what's happening as a result of maybe not just once a violent happening, but having it exposed to repeatedly, week in, week out. And out of all these areas that we identified and gave people an option to select from, the feeling unsafe at work, consider leaving job, and even considering leaving the profession. So over 1 in 3 people said they considered leaving their profession entirely as a result of experiencing these violent events over the past 6 months. Other areas that are really important: ability to work with patients, the broken trust with the employer, additional physical health care or mental health care, ability to work with staff. So as you can imagine, all these different factors are critical towards having an effective healthcare team. And when they're left unaddressed or even unknown because they're not being documented, they can create real problems for maintaining an effective staffing workforce. Next slide, please. We had a lot of people that just said they didn't want to report to these events when they happen. And part of that is, as you can see there, they didn't think anything would change. They've gotten used to it. Their supervisors are used to it. Their coworkers are used to it. It happens to them every day. They've been reporting this ad nauseum to multiple people. But in a lot of cases, nothing has changed in terms of safety of their working environment, new protocols implemented, new policies implemented. So we've got 2/3 of the respondents saying, I didn't think anything would change as a result. And so they just didn't even bother reporting. So there's a huge gap in knowledge in terms of what's really important to understand about the working environment. There's this other issue about where we have 21% or 1 in 5 saying they did not believe the act was intentional. And so there's this question about, what do you do when you don't think the person had intent or was conscious about what they were doing? Do you still classify that as a violent event or not? Should there be repercussions or not with that patient that's involved in that event? There's 20%, 1 in 5 didn't know if they should. Speaks to a lack of clarity about policies. What is the organizational policy around these events so that everyone is absolutely 100% clear about when they should or should not report? We also still had a 1 in 10 saying they're apprehensive to report because they're afraid of blowback on them from administration about making the report. And 7.5% or 1 in 14 weren't even aware what reporting system existed. Next slide. We had gotten just a ton of examples of people just writing open comments about what they experienced as a result of this event. So I just wanted to kind of share this with everyone. It's not always so much one event that causes harm. Some weeks verbal and physical aggression just stacks up. It's hard to pinpoint anyone that definitively causes direct harm, but it sucks. Berated by unhappy patients in triage about how bad of a job we're doing, being threatened with lawsuits, being threatened by mental health patients. All these things add up, makes me feel like the job I do is never good enough, makes me not want to be a nurse. Just, it is heartbreaking. The number of examples and stories that we got as a result of this survey. That speaks to another one of the reasons to do this kind of work is just to give a voice to staff that are involved in these events and let them know that they're being heard. And more importantly, also to start doing something about it and taking action. Next slide, please. So our next poll, so I know a lot of you may not have had access to the report yet, but I just wanted to share some of the highlights, some of the factors that came up. So once you get a chance to report, you'll see 75% experienced some form of violence. That's over the past 6 months. 11% of those violent events were caused by coworkers. 64% did not report it because they didn't think anything would change. Over half of the staff just no longer felt protected at work. And over a third considered leaving their profession as a result of the event, or all of the above. And all the above wins, so that's wins, unquote. Just, it's concerning, and it's kind of speaking back to Lisa's comment earlier about the need for maybe establishing more of a national consortium around this topic area. So we're looking actively for opportunities to help build knowledge about what the challenges are, what's driving those things, but even more importantly, what are some of the policies or activities or infrastructure changes or staffing changes that could work to help actually really turn this piece around. So I'm going to turn it over now to Pam, who will talk a little bit about some of the federal and state regulations, legislative efforts that are underway.
Thank you, Peter. Can we take down the poll slide?
Is it still showing?
Yeah, now that's good. Thank you.
Okay.
So my name is Pam DiNapoli, and I'm recently retired from the Department of Nursing at the University of New Hampshire. I am a nurse, and I am representing the New Hampshire Nurses Association. The New Hampshire Nurses Association is a membership association. We have over 20,000 nurses in the state. And just to give you sort of a context of what we've been doing related to this issue, probably in 2018, I worked with a group with Rosemary Taylor, who's on this call, and other faculty. And we wanted to know, we needed data to support some of our legislative efforts. What we were hearing from the legislators was that there was no reason to legislate prevention efforts because there really was no problem with violence because it wasn't being reported. So we went to the county where our state capital is, Concord, New Hampshire, and we got a sample of nurses to give a good picture, because we had introduced a bill, and this bill was going to be about enhanced penalties for healthcare workers. So we knew there wasn't a big appetite for legislative efforts in the state, but we still thought that if we had done this study and we had some good data, that we could really paint a picture for the legislators. So we went to Concord with our data, and actually it was what we thought, that it was inexpedient to legislate, and they didn't feel that enhanced penalties, and just echoing what both Lisa and Peter said, was a lot of their rationale, their big rationale was, one, that there's no data that this was happening. And the second thing was that even from our own nurses, we couldn't get support that they felt that it was a problem because the patients didn't mean it. And so a lot of our work had to be around convincing them that getting hurt was not part of your job. So while we weren't successful then with that legislation back in 2019. And interestingly, we also didn't have hospital association support, which is really a national, when I talk about what we were able to get done, we had gotten calls because the National Hospital Association really doesn't back these legislative efforts. So what we did was we got a study committee, and a lot of bills in New Hampshire, what happens when they don't want to do something, they create a study committee and it kind of dies. But we didn't let this die, and we got a bunch of key stakeholders together, people from Lisa's hospital, the New Hampshire State Hospital. We had hospital security guards. We had the ACLU. We had a broad group of stakeholders, and provided testimony to this committee that was developed. And so out of the committee came recommendations for 2 legislative efforts. So we felt like we were getting close. This was the closest we were getting. So this was why, and it was right at COVID. So in 2020, that's when we applied for this grant through the Endowment for Health, and we were able to contract with Peter to really develop a better methodology and a good survey that we could use this data to support our legislative efforts this time around. So every time that we were faced with the statement that violence wasn't happening, we would be able to provide about 2 data points. So what was introduced, Senate Bill 459, and I think you'll get the slides and you can download the text for this bill. But essentially what it did is introduce, there were 3 things. And one was to develop workplace violence prevention programs in all of our hospitals. And interestingly, at the same time, this was in that January, the Joint Commission came out with their new, much more specific recommendations for what violence prevention programs should include and what data should be collected. So we were able to have that language. So we took that. Our second thing was what we had are calling our Commission on Workplace Safety. So we currently have a coalition for a Commission on quality. So a lot of quality metrics are reported to the Hospital Association. They trend them, they discuss them, and then they report out. So we thought that that was an existing model that we could put into this legislation. So we outlined what this commission would look like. And it was really our first effort, and what Lisa and Peter were talking about is really trying to get all of the people, the key stakeholders across the state to pool data and really look at the scope of the problem and be a collective think tank to talk about issues. And then the third part of that bill was what we called warrantless arrests. So currently you have to, the violence has to be witnessed in order for them to arrest the person if it's a felony. And so what we were seeing as happening was that people were being administratively discharged if they were violent. So somebody would go in the hospital, they would be violent, they would then be discharged, go out the front door, come back in the emergency department. And really nurses and all healthcare workers didn't feel safe at all and really wanted this sort of a version of enhanced penalties. So interestingly, just one other little comment. So if you looked at the data that we collected, and 97% of those healthcare workers said that they were victims of verbal aggression. When we took this to the legislature, they took out the definition of verbal aggression as violence because they didn't feel that words should be criminalized. So despite our language, and we were happy overall with the bill, verbal aggression is not in the bill. So that bill, we were really happy, passed bipartisanship. It was signed into law in July. And we had this current year, 23, to really develop the commission, to come up with the rules, come up with our reporting structure. And we were really moving along. We felt really, really happy. Our new legislators were introduced here in 2023. And the first thing that they did, because it's a fiscal year, was to ask that this commission be delayed by 2 years. So we know that if the commission is delayed by 2 years, it's pretty much dead in the water. So our new fight this year was really to continue to keep that momentum going. And we had a hearing yesterday, and it's going to stay in the bill. And we're really hoping that we're going to have those efforts continue to move. The other interesting thing, though, and I think that this overarching in all of this legislative picture is it's a hot potato. Nobody wants it. So the reason that they wanted it out of this legislation was because Health and Human Services didn't feel like it was something that they had a good understanding of what needed to be done or what needed to be reported. And they wanted it in the Department of Labor. The Department of Labor said that they didn't want it because it was healthcare information and that was protected information. So there's kind of this, well, it's your problem. It's not my problem. And that's what we're really concerned about right now. So how we're going to keep this momentum going. So then in the same context, that warrantless arrest piece was taken out of the original SB 459 before it was signed. Again, the feeling was that this isn't criminal behavior, it's unintentional, and you shouldn't mandate that people be arrested for this behavior. So we were a little disappointed, but again, that piece of legislation was just introduced in isolation to the Judicial Committee, and we had a lot of good testimony on that. Unfortunately, that was deemed inexpedient to legislate. So we're still not going to have any legislation around enhanced penalties, but we do feel that we have a good foundation for developing a commission and having good workplace violence projects in our hospitals. And we do have strong support from our hospital association this time around. Just looking at our area, one of the things we do in New Hampshire is look to see what is everybody else doing, because we have a lot of borders as states, and we want to make sure that our penalties are consistent with other people's. Same thing is happening pretty much in the Mass legislature. They had a bill introduced probably 3 years ago, and it hasn't been acted on in recently. Although there have been efforts in Massachusetts by their hospital association to begin to support healthcare workers. So again, the feeling that this isn't something that can be regulated, that it really belongs at the hospital or the local level. Connecticut this year just introduced legislation that they would like to put finances to the hospitals to introduce hospital-wide security grants so that they can beef up their security measures. So that's a different direction, sort of a less policy and more finances and infrastructure. So that's one thing that we could possibly think about in the future. Although we're not a state that puts a lot of finances into prevention. Next slide. The last thing I wanted to just mention is federal legislation. So in 2021, 2022, HR 1195 was introduced. It's a workplace violence prevention in healthcare and social services. Again, we really looked when we were writing our own New Hampshire legislation, we really wanted to be consistent and evidence-based. But so what were other people looking at? We looked at all the different states. We have a report of all the different states that have enhanced penalties, that have workplace violence prevention policies. And so we looked federally, and this bill, Workplace Violence Prevention for Healthcare and Social Services, made it through the Senate in 2021, 2022. And now it was difficult to find a representative to take it to the House. But recently there was House support. But the federal government got some sponsors to sign on. So we're hoping that this comes back this year at the federal level and at least gives guidance to states for some of their own local legislative efforts. Again, interesting with this one, the American Nurses Association is kind of neutral on this legislation because they don't think it goes far enough in terms of prevention. So, and I think that we'll talk about this at the end of the program, is that this word prevention and is workplace violence really preventable, and what are some good strategies? And like Lisa mentioned, we don't have a lot of good evidence. So when you put the word prevention in, people say, well, I don't really think this is preventing anything. So give me something that's more preventable. So again, following at the end of what Peter said, is that we're really hoping that a commission or a coalition can really begin this conversation about violence prevention strategies. And as we were writing this legislation, we looked to our own violence prevention practitioners in the state to find out what they were doing. And our next presenter is Stacy Carroll, who was really on the direct front lines with this. And her hospital was one of the groups that participated in our survey and had a lot of creative and innovative ideas that we hope that we'll be able to use in our discussions with our key stakeholders. So I'd like to now introduce our next poll question. So when your organization collects data on violent events impacting staff, do you also collect information from the patient's point of view? And that question comes from the fact that we're talking about, staff being violence perpetrated against them, but do are we considering what the patient, is it patient fear? Maybe they're acting out of fear. They're in an unfamiliar circumstance. So do we collect information from the patient's point of view? And I don't mean just their diagnoses or if they're substance users, but really, what did that violent event mean to them? So I'll give you a few seconds to answer that. So unsure. So I'm wondering if that means they're unsure because you're really not sure what data you're collecting, which is probably one of the big problems with this is what data should be collected. And then our other follow-up question could be, where does this data go? Is there a central repository where there are conversations? And in our state, we know that only events that result in severe harm or death are mandatory reporting. So most of this reporting is kept internally, and hospitals don't want to share that because they don't want to be the hospital that is where violence occurs. So it's an interesting conundrum around policy, prevention, and data. So Stace, I'm going to turn it over to you.
Well, thank you. So there were a couple of things that they've said that I'm going to touch back on, but I am Stacy Carroll. I have a very odd background. I'm the Director of Emergency Management and EMS Coordination at Southern New Hampshire Health in Nashua, New Hampshire. So I have been a nurse. I've been a nurse for 26 years, primarily in the ICU. And my background goes towards protection. So I'm also a Lieutenant Colonel in the Army. I also work with our local SWAT team on their EMS unit. Protection is kind of what I do. And I say that because when you're looking at your workplace violence committee and standing one up, you need to find someone who is vested in it. This can't be kind of an additional duty or something you're just tagging on to someone else. You need to find somebody that's very vested in the protection of your staff and your patients and the people in your building. I think that it goes a long way when you find someone with the passion to do that. So I hope that comes across in what I'm about to talk about. So we have started at my hospital probably a good 6 years ago or so, a patient flagging system. And it was even before we had Epic. It was in our old system that we had, which is where this wonky little icon that you're looking at comes from. So that little icon is called the patient safety flag, but we jokingly around the hospital call it the don't step on the Legos guy. And why it's the don't step on the Legos guy is because when you step on Legos, it hurts. And what we do is if we have a patient who has been here, who has had a history of physical assault, verbal assault, or sexually inappropriate behavior, as an inpatient, that patient will have a little magnet of our don't step on the Legos guy that sits outside of his patient door. The reason it sits outside the door is because it's not just our clinical staff that get harmed by patients. This initially from 6 years ago happened because we had a dietary member that walked into a patient's room who had been incredibly violent. And we don't necessarily talk with our dietary staff and tell them, hey, this guy's been violent. Here's a whole bunch of HIPAA stuff we can't talk about. We can't do that. So unfortunately, this gentleman from the kitchen walked in and took a tray to the face by the patient and knocked him out cold. And that was awful. And he wasn't doing anything but trying to bring him his lunch. And now what we have is this little flag system that goes outside of our patient doors. And everyone during house orientation gets this orientation about patient safety flags. And if they're not part of the patient care and they need to go into that patient room, they see that flag, turn around, go find a clinical staff member and ask if it's safe for them to go in. Is it safe for them to go in by themselves? Do you want maybe to leave the tray outside and you guys can take care of it? But it's keeping our chaplains and our patient and family services staff, our environmental staff, safe in addition to our clinical staff. It has now morphed into a little bit further now that we have Epic and we're able to put into our electronic medical record system these flags. These flags are now a product of an occurrence report. So we have, as something that Pam had said, you know, there's hospitals that don't want to be tagged as a violent hospital. My hospital has been known for years as one of the highest reporting occurrence report hospital in all of New Hampshire. And it's not because we're overly violent. It's because we have our staff that know we'll do something about their occurrence reports when something has happened. So we give them feedback that something has happened, that we've looked at the case, that we've flagged the patient. We keep them involved in what the decision has been. So because of that, they know that we're going to do something to take care of them, and they'll continue to report. So what happens at the moment is if someone comes in and is physically assaultive, is verbally assaultive, not just having a bad day and dropping some F-bombs, but actually being verbally assaultive, where they're condescending, belittling, whatever that may be. But if it's those and or being sexually inappropriate, they put in an occurrence report that comes to our workplace violence committee. I look at it as the chair, as the clinical member, to make sure that it's not something that doesn't look like it's reproducible. Someone's going to come back and do this again, it's very likely. Then yes, we will then assign the flag to the patient's chart where it stays. They can't see it on the patient portal, but we do have the conversation with the patient if they ask what it is, so that we can explain it's our way of keeping our staff safe. This patient safety flag initiative that we've used is something we're trying to use with our local EMS agency as well, so that they know when they're branching out into the community to pick these patients up, to our other local hospitals. So it's something we're trying to pass on to keep other people safe, not just us. Next slide, please, Carla. I should have one more. The rest of the initiatives buy right into that safety flag. You heard a couple of folks talk about senior leadership buy-in and whether or not their leadership will do something. So a piece that we found is that most of our leadership in a hospital are far removed from the bedside. Outside of our chief medical officer, as well as our chief quality officer, nobody else really sees patients. So again, like Pam had said, at that level, they don't really understand what that violence is. And we're still in the years of thinking that, it's a doctor yelling at a nurse, or it's a dementia patient who thinks that it's 1912 and is trying to fight you off. They're thinking that that's all that it is, and it really isn't. And until you bring them down to the level where they can see and read these occurrence reports of nurses that are getting assaulted, and security officers that are having their hands broken, and just awful, terrible things that are happening to them, they don't really know. And we then brought up the retention issue and started to talk through retention and said, if our staff don't feel safe, why do they want to stay? We've now become one of the hospitals where people will want to come to us because they know that we're going to protect them. It's a great retention tool to be able to use, just to be able to do what you should do, which is keeping your staff and your patients safe. Our senior leadership team has gotten so far now that they love hearing us talk about this. We actually give them a dashboard quarterly that tells them where we're standing for how many safety flags we've applied in that quarter, how many assaults we've had, what we've done, if we've had any administrative discharges. We just recently had a security officer that we had who was very badly injured by a patient. And pardon me, it was not recent, it was 4 years ago, but it was just recently finally resolved because we did bring that patient through helping that security officer to court, and he was charged. But it's sticking with your staff to let them know that they can press charges if they so want to. We have walked staff members through, can't think of the word, restraining orders on patients that have terrorized them. And it's a matter of just staying with them and helping them. That senior leadership agreed for us, we created a peer support network within the hospital specifically for our staff to be able to talk through any of these issues, because as Lisa was talking about and Pam did, those words stick with you when you've heard all day from your patient how stupid you are, or that you shouldn't be doing this job, you should be collecting trash, whatever it may be. Those words really do weigh on you. So senior leadership buying in was very important. Encourage reporting, yes, and I talked through, as long as you're showing that you are dealing with those issues or even responding to people who have put in occurrence reports, they feel like you're paying attention and you're hearing them. And that encourages them to do more. And then it encourages them to encourage their new people that are coming in. Hey, they do listen to us here. Put those reports in, they'll pay attention. Security is one of the ones I love to talk about, because our security partnership that we have, our security officers that we have are amazing. And they run on proactive behaviors. So an example of those proactive behaviors goes back to those safety flags. If we have one of our offsite locations who has a patient that's coming in for an appointment and has a history of being violent, those offsite locations have to call 911 and call for a police detail essentially to come out and assist if there's a problem. However, what we do is if they know that patient's coming in, they call out to our director of security and say, hey, I have this guy coming Tuesday at 9 a.m. Can you send a standby? So our director will send one of our security officers out to that offsite location just to ward away evil spirits, like I like to say. It's an ICU nurse term. Ward away the evil spirits, hopefully. And then nothing bad happens. The security officer says hi to folks that are over there and then comes back to the hospital. But those proactive behaviors are what are helping to keep our staff safe, instead of having to react when something bad is occurring. Last but not least, the celebrate and support. That's really what this is. We have had some of our, the one that Pam had listened to because it was in part of our testimony, was one of our nurses in the ED who had been stalked by a patient. Her family had been threatened by this patient. And we walked her through getting that temporary and then permanent restraining order. And we have supported her through that to the point that she now talks to other folks. She presents in places to let them know, hey, this isn't acceptable. She talks through some of our orientation programs where we go through intent doesn't matter. It doesn't matter if there's a patient who is harming you through intent or not. They're going to knock your teeth out either way. So you need to be proactive to take care of yourself and know that just by putting an occurrence report in or getting a safety flag isn't something where you're penalizing anyone. It's where we're just keeping our staff safe. So we need to know those things. There are lots of initiatives, and you keep hearing everybody talk about this coalition, but if there were a repository to be able to put some of these initiatives in, that would be fantastic. I would love for people to take our Don't Step on the Legos guide and put that through every hospital that we could find and keep more and more people safe. But there just isn't that repository yet. So I already gave you the answer, but our poll question is, do you report a violent event if the patient is not oriented or in your assessment cannot form intent? Kind of gave you the answer. I'm a really bad nurse educator. The Army in me. I'm supposed to give you the answer before you take the test. You should pass this one. See? Look at that. I love it when people can pass tests and learn something at the same time. All right, and Carla, this should be off to you.
Yes. Okay, I'm off mute. I know we're kind of getting toward the end of our time, so I'm going to be very quick. I am Carla Armenti, and I run the New Hampshire Occupational Health Surveillance Program funded by the National Institute for Occupational Safety and Health, and it's been my pleasure working with this group. Peter and I have worked for a long time together, so this is really exciting. You've heard about our research. We've disseminated it. It's on my website. We've kind of spread the word pretty widely. We have created this New Hampshire Hospital Violence Prevention Work Group with our original 6 hospitals. We do hope that we could expand this group to other interested hospitals, and many others have expressed interest. However, as Pam mentioned, this new State Commission on Healthcare Violence has been established, and they're looking to formalize under state statute the creation of a volunteer consortium, and then working to identify the key roles they'll be taking on. So we thought that we might wait to see what the outcome of that might be. Whoops, missed one. Yeah, okay. And if nothing happens in the State Commission by the end of this year, and you also heard from Pam how things just they just wait for time to go by, and with no action, we'll reevaluate our steps. We definitely want to try to expand our group in New Hampshire. How can we fill in the gaps? More data collection. Can our survey be implemented in all of the hospitals in New Hampshire? What further research can we all collaborate on? How do we strengthen advocate voices? And then perhaps launching pilot studies, as Stacy mentioned. Maybe we can build some collaboration on promising practices. So I have to put this up quick. Okay, so Peter, I think we want to share the survey with everybody, and then hopefully, Kendra, we have time for some of the Q&A.
And if not, what we'll do is we'll collect the questions and we'll send email responses out to everyone, so that you get some feedback on questions. So if you have a couple minutes to write a question real quick, please do so and add that to Q&A. For the next steps, what is happening nationally, I put a little quick survey together. I would ask that everyone here participate. It's just a very brief survey asking about just other examples of kind of best practices, maybe in your area, legislative activity that's happening, and to get a sense of broader interest in trying to form a national coalition, this kind of idea of a resource repository where, where great work that like Stacy is doing or other hospitals are doing, that they found this innovative practice that has really dropped down the incidence of violent events. It's really important that we're able to share that information. We have a mechanism for doing that. So please just take a few minutes to take a look at that survey, give us some feedback, let us know if you would be interested in continuing on with the conversation.